Hello, everyone, and welcome to today's webinar, Intimate Partner Violence SBIRT, or Screening, Brief Intervention, Referral to Treatment, the WINGS Intervention Model. I'm Tracy McPherson, and I'm going to be your moderator today. I am at NORC at the University of Chicago. I've provided an email address for everyone in case you'd like to follow up with us after this webinar about any of your SBIRT-related needs. You are welcome to contact me at any point, and I'll give you a reminder later on because we have an opportunity to help provide technical assistance to you as you're implementing SBIRT in your location. So please take advantage of contacting me. I'm glad to help you in any way that I can. And this webinar is produced in partnership with the Brief Intervention Group, or the BIG Initiative, NORC at the University of Chicago, and the National SBIRT ATTC. This webinar is actually part of our 2016 SBIRT webinar series. As you can see, we started off much earlier in the year, launching with a range of topics, including a really nice overview of SBIRT and resources that I would encourage many of you to actually review the on-demand. There's a lot of new things out, and it's really nice kind of one-stop shop for some of the resources that are freely available and out there. And if you look at our schedule over the course of the winter and the spring, you can see we've had some hot topics, some special population topics around adolescence and teen substance misuse. And we've also had some hot topics that, don't get quite as much attention, but are sort of emerging on the scene. For example, gambling screening. And then, of course, we built in some webinars that are very, very useful, but for both faculty, educators, instructors, and practitioners on how to train others in motivational interviewing and how to use case studies to help train people and educate people on how to do screening and brief intervention. And also, last month, actually in May, we had a new topic around prescribing guidelines, doctor shopping, which includes nurses, and intervention skills that nurses and other healthcare professionals can use in addressing prescription drug abuse, another hot topic. So I would encourage you to take a look at this series. It's all available on demand 24/7, and to share it with your colleagues. There's a downloadable flyer you're also welcome to share, and we hope you'll take advantage of it. All of the materials for today's webinar and all of the webinars in our series are available on our website. We have a dedicated page specifically for this webinar today. We already have the PowerPoint slides that are up there available for you to download. We have other materials and resources that may be related to this topic also on the website. And if there are other resources that emerge during the webinar today that we think might be useful to you, we will post them there. The recording will be made available there as well, and this is also the place where you can access the certificate of completion as well as any evaluation surveys. And the webinar today offers 1.5 NADAC CEs. During the webinar, you'll be able to ask questions at any point, and we have many people joining us today. So I hope that as you realize your questions, that you get them into the questions pane, into that questions box. Typically in your upper right-hand corner, you'll see a dashboard that allows you to actually click on the questions area and type in your question. Go ahead and get those in there because I'm thinking we're not going to be able to get to all of them. We will try. At the end, we'll have a Q&A period, and we will really try to get to as many as we can. So I would say get them in the queue as soon as you think of them. And behind the scenes today is our technical facilitator, Misty Story. If you have any technical questions or other concerns, you can type those into the pane as well, and she'll be able to assist you with what you're dealing with. And now it's my pleasure to introduce our presenters. We have two presenters today. Our first presenter is Dr. Louisa Gilbert. Dr. Gilbert is an associate professor at the Columbia School of Social Work and a licensed social worker with 25 years of experience developing, implementing, and testing multi-level interventions to address HIV/AIDS, substance abuse, trauma, partner violence, and other co-occurring issues among vulnerable communities in the United States and Central Asia. She has served as the co-director of the Social Intervention Group since 1999 and the co-director of the Global Health Research Center of Central Asia since 2007. Her specific area of research interest has concentrated on advancing a continuum of evidence-based interventions to prevent intimate partner violence, or IPV, among drug-involved women and women in the criminal justice system. She's published over 100 papers in peer-reviewed journals from this research. So I welcome Dr. Gilbert, and I also would like to introduce you to Jessica Rowe. She will be joining us today as a second presenter. And Jessica Rowe is a senior program specialist and oversees the Triangle Initiative at the Columbia Center for Teaching and Learning. She works with faculty and researchers to bring projects that unite research, classroom learning, and social good to fruition. She's worked on the ICAP Nursing e-learning platform and Option B+ course, which extends teaching and learning in nursing schools across Africa. The Teach Recovery Project, which teaches health professionals about cognitive dysfunction and remediation, and many computer-supported behavioral interventions with the Social Intervention Group and the HIV Center for Clinical and Behavioral Studies. She has a Master's in Design and Human-Centered Design from the Institute of Design at the Illinois Institute of Technology. So it's my pleasure to welcome Dr. Gilbert and Jessica Rowe, and we are delighted to have you as our presenters today. And I am going to turn it over to Dr. Gilbert.
Thank you very much, Tracy, for that warm and generous introduction. I'm really delighted and honored to be presenting in your SBIRT initiative webinar series, which is just so great to see this moving forward on so many different levels. I also really want to welcome the audience and thank them for taking the time out of their busy days to learn more about this IPV SBIRT model today. So what I hope to present today is to really give you an idea of the scope of the problem of intimate partner violence among women who use drugs or alcohol, and really the different types of relationships that many multifaceted relationships between different types of drug use and intimate partner violence. Then I want to give you a clear overview of the IPV SBIRT model that we developed, which is called WINGS, and that actually stands for Women Initiating New Goals of Safety, and talk about how we converted a case manager version of WINGS into a computerized self-paced version of WINGS, and our research evaluating the relative effectiveness of the computerized self-paced version versus the case manager WINGS. And towards the end, I want to sort of talk about the different steps you need to take to sort of assess organizational readiness to implement WINGS and some of the future directions that we're going in for WINGS.
Dr. Gilbert, you're on mute.
I'm trying to advance.
Yes, I think your video is on as well.
Oh, okay.
No problem, just take your time.
Okay, let me go back here. Okay. Okay, so sorry about that. So by the end of this presentation, I hope you will all be able to kind of identify the different types of intimate partner violence among women who use drugs and relationships between IPV and substance misuse, describe the core elements and evidence base of the WINGS model, and really describe how the different modalities of the Wing SBIRT model address IPV and assess the organizational readiness to implement Wings. So let me just step back a little bit and talk about our journey in developing Wings that my colleagues and I at the Social Intervention Group really started about 25 years ago when we were conducting randomized controlled trials of relapse and HIV behavioral interventions with women in drug treatment and women who use drugs in the criminal justice system. And while we were conducting these interventions, many of the substance-using women who were participating in them presented with severe physical, sexual, and psychological violence from their intimate partners. And this was a huge barrier for them accessing and staying in drug treatment, as well as a major challenge for them to negotiate safe sex with their partners. And at that time, and I think it's very true today, very few of these women were able to access any IPV services. And this really led us to refocus our relapse and HIV interventions to address IPV and to think more deeply about broader public health strategies that would identify women who use drugs or alcohol at risk of intimate partner violence and link them to appropriate services. And this, in turn, led us to embark on our Wings journey. And our effort to really develop an IPV SBIRT model mirrors SAMHSA's wider SBIRT initiative of identifying folks in early stages of experiencing drug or alcohol-related problems and linking them to appropriate treatment. So currently, as many of you may know, only 1 in 10 women who need substance abuse treatment are receiving it. And part of the whole SBIRT initiative is really to figure out how can we go after that other 9. I want to say that less than 1 in 10, about 6% of women who need, who are substance-using women who need IPV services are receiving it. So our challenge is how do we find, I would say it's really about the 95% or more of women who are experiencing intimate partner violence and link them to IPV services. So right now we're going to be doing a poll, and I just really want to know where you're coming from. So if you can all just fill out this poll and submit it, that would be great. That way you give me a sense of where you're from. And at the end we'll be able to feed back the results. You'll see them. Alrighty, so we have about 24% in healthcare, 3% in criminal justice settings, 41% in substance abuse DV programs, 16% are coming from academic or research backgrounds, and 17% other. Okay, so we have a broad range. That's very helpful. Okay, and okay, and now what I'd like you to do is to do another poll, and just on a scale of 1 to 5, how comfortable would you be screening women who use drugs or alcohol for intimate partner violence, identifying service needs related to IPV, and linking them to IPV services? 1, not at all comfortable, 2, somewhat uncomfortable, and you can go all the way up to 5, very comfortable. Okay, so we have a range here again. About 3% say not at all comfortable, 10% saying somewhat uncomfortable, all the way up to 31%, 1% saying very comfortable. I'm hoping by the end of the series we can, increase the more people will feel comfortable with this as part of this talk. I'm just trying to advance the slides here.
You did advance them on my screen. It's taking a minute to catch up.
Oh, okay, so it's taking I think it's,
I can't find the,
trying to go back. It's advancing. Sorry about that. Okay, we got it here. Sorry about that. So let me just cover now a little bit about just the whole scope of intimate partner violence against women in the United States. So we are 1 in 4 women who experience ever physical or sexual intimate partner violence in their lifetime. And every day, 3 women in the U.S. are murdered by a partner, and 12 million women and men experience IPV. So this is a huge public health threat. And now let's think about what does that look like among women who use drugs or alcohol. Well, I mean, the research, there's still a lack of population-based estimates on the prevalence of different types of intimate partner violence among women who use drugs. But among clinical and community-based samples of women who use drugs, past year intimate partner violence are found to range between 23% and 50%, which is like 5 to 7 times higher than rates found among the general population. Moreover, I think there's emerging research with sort of rigorous meta-analysis and systematic reviews that have found strong relationships between different types of intimate partner violence and different types of alcohol and drug use, both among survivors as well as perpetrators. And it varies by type of drug, type of intimate partner violence, and whether or not both the perpetrator and the survivor are drug involved. Particularly strong relationships with alcohol and with cocaine use. So what the graphic on the right is really showing what we called the syndemic of intimate partner violence, substance misuse, trauma, and the really super additive effects among these co-occurring epidemics. And a syndemic may be defined as a set of closely intertwined and mutual enhancing epidemics, and in this case we're referring to the co-occurring epidemics of substance abuse, violence, and trauma, all of which are reciprocally influenced and sustained by the larger risk environment in which they are embedded. And the term syndemic suggests that the co-occurring epidemics of substance abuse, violence, PTSD-related trauma, and we might as well throw HIV in there, are not merely co-located in space and time, but they're inextricably linked and synergistically reinforced by multiple behavioral, biological, and structural mechanisms, which create these super additive effects. So many of you may be familiar with the power and control model. For women, there's actually a model that was developed quite a while ago for women who use drugs or alcohol. And it looks similar to Women for General Women, but intimate partner violence constitutes a constellation of abusive and controlling behaviors that includes sexual abuse, physical abuse, that's the legal definition, but to broaden it out, it also includes psychological abuse, emotional abuse, verbal abuse, and economic abuse. And where it looks different for women who use drugs or alcohol is that often their partners encourage them to start using drugs or alcohol, encourage the drug dependence, prevent them from getting into drug treatment, and then also use threats and psychological abuse to keep them using drugs. They may also threaten them to take away their kids, by calling ACS if because of their drug use. And then, of course, with sexual abuse, it often occurs under the influence of drugs or alcohol, as does physical abuse. So there are multiple mechanisms linking substance misuse and IPV. Gender-based power imbalances in spending resources on drugs, procuring drugs, splitting and using drugs often create relationship conflict where women will fight back to get an equal share. Economic conflicts about spending resources over drugs can also ignite physical conflict. Partners' controlling behaviors prevent women from getting into or staying into treatment, as I mentioned before. And then partners' verbal abuse often focuses on putting women who use drugs down for their drug use and reinforcing their stigma as women who use drugs. They'll never be good mothers or partners because of their drug use. So they suffer the stigma more than, I think I would say, men who use drugs. And then social expectancies for men and women who use drugs or misuse alcohol also differ, that reinforce negative gender stereotypes and abusive patterns. If a man physically or sexually hurts a woman while he or she is under the influence of drugs, he's more likely to be excused and not held accountable for his actions. And then some research also suggests that the use of certain drugs, alcohol, cocaine, and methamphetamines in particular, may increase partner expectancies, demands for unwanted and unprotected sex. If a woman refuses to have sex under these circumstances, her partner may retaliate with physical or sexual violence, particularly if she's been given alcohol or drugs by her partner. And the psychopharmacological effects of drug use of both partners may create impaired judgment, emotional volatility, irritability during withdrawal, and paranoia, all of which increase the likelihood of IPV. And then the psychopharmacological effects of substances also lower levels of serotonin, which may increase the likelihood of aggression and impaired judgment. And then the other last sort of real connection is linking the sort of emotional and physical pain from experiencing the violence and often the PTSD-related trauma following it can trigger women to continue using drugs and alcohol to self-medicate. So in addition to these multiple ties between substance use and intimate partner violence, they also share common multi-level risk factors. Poverty, unemployment, access to health affect both, drive both IPV and substance misuse, as does neighborhood levels of violence, incarceration, access to services, and that at an interpersonal individual level, younger age is associated with both IPV and substance misuse among survivors and perpetrators, as well as the mental health status of both partners. So the other thing I want to mention is that I really want us to think about the universality and intersectionality of women who use drugs as survivors, and that types of intimate partner violence varies tremendously culturally and covers a wide range of romantic, dating, sexual, and marital relationships that occur from adolescence to elderly. If you think of a young woman who's hooking up with maybe someone who she's casually met through the internet and is under the influence of drugs or alcohol, her risks for potential sexual violence, all the way to an 80-year-old woman who's addicted to prescribed opiates, who's vulnerable to psychological abuse from her spouse. So it's a huge range, and I want to say that the prevalence rates are similar among women in same-sex and heterosexual relationships, but have been found to be higher among women who identify as bisexual. This is recent CDC data. And I want to say that this presentation will actually focus mostly on women who use drugs, who are survivors in both heterosexual and same-sex intimate relationships. So let me just step back. A lot of you are familiar with the SBIRT model, but for those of you who may not be, let me just briefly say that they've been around for about 30 years. We started with really screening for alcohol use and then providing a brief intervention to increase insight and awareness regarding substance use and motivation towards behavioral change, and then providing referral to treatment. And more recently, SBIRT models have been used for depression and prescription medication abuse, as well as other types of substances. So we thought about using a SBIRT model to really identify women who use IPV among women who use drugs, raise awareness of the different types of violence they're experiencing, and conduct a brief intervention to motivate them to develop a plan to increase their relationship safety, which may include safety planning, increasing their social support, or referral to treatment. And the research shows that women who talk to a healthcare or social service provider about their experiences of IPV are 4 times more likely to access IPV-related services and 2.6 times more likely to leave an abusive relationship. And I want to say here that IPV SBIRT models may be also combined with substance abuse SBIRT models and other types of SBIRT models to yield a fuller assessment for differential treatment planning. So the brief IPV interventions based on SBIRT models have been found to be effective in identifying IPV and linking women to services in healthcare settings. To date, there are really no SBIRT models, IPV SBIRT models that have been developed specifically for women who use drugs or alcohol. And IPV SBIRT models, the research shows it suggests that they're safe and acceptable to women if they're conducted in private settings. I just want to talk a little bit about where the IPV SBIRT models fit in the continuum of different types of IPV interventions, and using a prevention public health impact pyramid that was adopted from Frieden in 2010. So it's really an intermediate strategy that can link a broader community of women who use drugs who are at risk of IPV to extended treatment. We actually have a number of trauma-focused interventions for women who use drugs that address IPV. We've done very well in that top category. But the issue is it goes back to finding those 9 in 10 women who are in the community using drugs and experiencing intimate partner violence and not accessing services. And that's the role that the SBIRT models can play and have a deeper population impact. So just to drill down a little bit more in this model, as I mentioned before, the IPV SBIRT model can be combined with PTSD SBIRT models and substance use disorder SBIRT models, and to really identify women who are using drugs or alcohol who are at risk of IPV and referring them to the different types of brief or extended interventions that they may need to address the IPV trauma and substance use. And I don't want to lose sight of the other, what's really important and what's needed are community-level interventions to address the syndemics of IPV, HIV, trauma, and substance use, as well as we need to continually look at legislative policy and advocacy efforts to address the macrostructural factors that are affecting this syndemic. But the data that we gather from these SBIRT models can actually be used also to inform policies on prevalence rates among different groups of women who use drugs. So let's go back to that question. Where are we going to find these women who use drugs who are experiencing intimate partner violence and need services? And so when we really thought about this question, if we were to go to, there are certain whole systems of services that are serve a disproportionate number of women who both use drugs and are at risk of intimate partner violence, and that is community corrections or the criminal justice system, emergency care and some primary care types of facilities, HIV, STI prevention, treatment and care, as well as child welfare services. And I'm curious to hear from you, maybe all from during the question and answer period, if you have other ideas about where this can be taken to really find the 9 in 10 women. That is our goal. So let me just talk, we spent 5 years conducting research on IPV and substance use among women in emergency care. That's emergency, between 10 and 40% of women in emergency care experienced physical or sexual IPV in the past year. These are very high rates, and there's a number of reasons why that's so. IPV-related injuries account for about 25% of all injuries in emergency departments, and many women would rather go to an anonymous emergency care setting to get help for minor injuries or symptoms related to abuse rather than to their primary care doctor because they don't want to disclose abuse. And substance use and IPV are strongly associated among women in emergency care. So in terms of looking at IPV among women in the criminal justice system, 57% of women in jails and prisons have reported ever experiencing severe physical intimate partner violence. This is much higher than population estimates. 37% of incarcerated women have experienced rape. The sample nationwide is about 1 in 5. 89% of incarcerated women with intimate partner violence have a history of drug use. And IPV really increases the likelihood of not only relapse, but recidivism. So there's a big push to sort of address the issue of intimate partner violence in the criminal justice system. And as many of you know, 1 in 100 adults are incarcerated in this country, and even more are in community corrections. So it's a huge population that we're talking about. And so that's what we really decided to focus on is how can we, going back to our whole thing of how can we reach women who are using drugs at risk of intimate partner violence. We decided to focus on community corrections as a setting, one, because it serves a lot of women who use drugs, and it also serves a lot of women who are at risk of intimate partner violence. And I want to take this moment to thank my fabulous team who did this, went on this journey with me, our project director, Don Goddard, and Stacy Shaw, as well as Jessica Rowe, who you'll hear, who helped develop the tool. And I also really want to thank Maria Almonte and Deputy Commissioner Sharon Goodwin, who are our community partners in probation and community corrections that helped us conduct the study. And most of all, I'd like to thank the women who participated in the study, without whom we wouldn't be able to present this data here today. So the aims of Project WINGS was really to develop an IPV SBIRT service model for women who use drugs in community correction settings and convert that into a computerized self-paced tool. And we wanted to assess the feasibility, safety, and acceptability of implementing a computerized self-paced version of WINGS, as well as the traditional case manager modalities WINGS in community correction settings. And then to compare the effectiveness of a computerized SBIRT tool versus the same SBIRT intervention delivered by a case manager on identifying different types of intimate partner violence, increasing their self-efficacy to address intimate partner violence, increasing their social support to address intimate partner violence, linking women to different types of IPV services, as well as reducing drug use. Those were our outcomes. I just want to take a moment here to say that when I say case manager, it can mean a counselor, caseworker, social worker, and we've even delivered WINGS with peer advocates. So it's a wide range of helping professionals and lay professionals who can deliver this. So WINGS was a randomized controlled trial that was funded by NIDA, and we enrolled 191 women from community correction sites in New York City. To be eligible for the study, women just need to be aged 18 or over, report using any illicit drugs in the past 90 days, or heavy drinking episodes, or being in alcohol or drug treatment, and also being in a relationship with some type of intimate partner in the past year. So we randomized about half the women to the computerized self-paced version of WINGS, and the other half were randomized to the case manager version of WINGS. We had a high retention rate at the 3-month post-assessment. We were able to get to 90% of the women, which we were proud about, given that that a lot of these women are on probation and in and out of jail. So it was we were very happy with that retention rate. So now I want to talk a little bit about the sort of whole background and philosophy of the WINGS IPV SBIRT model. It's really based on a harm reduction model, and the idea is to move women to a safer position, but let them drive the change, let them decide what choices they want to make in terms of their relationship. It adopts a completely non-judgmental attitude, whether they want to stay or leave in these relationships, that they're experts on their issues, and really the primary agents of addressing intimate partner misuse or any other issues that they may be experiencing. It also recognizes that poverty, class, racism, sexism, heterosexism, and other social inequalities affect both people's vulnerability to and capacity for dealing with substance misuse and IPV. So the other thing, as many of you know, with SBIRT models is really we integrated motivational interviewing as a core clinical skill. It's a client-centered method of communication for strengthening internal motivation for change. And MI strategies are really tailored to whatever change a client may be at with respect to initiating or maintaining behavioral change. In this case, there may be women who are not at all thinking that the relationship conflict that they're experiencing or abuse experiencing are problematic, or even they may not even think of it as abuse, to women who are really ready to make changes. And the core clinical skill that we used of MI for WINGS was really a skill called ORS, and ORS is sort of a communication interaction strategy that you have with participants or clients, and I'm going to call clients here participants because that's what we call them in our work. And OR standing for O, asking open-ended questions. Tell me a little bit about the relationships that you're in, and letting the women as much as possible sort of tell you their situation. A for actively affirm and validate what they're saying. R for using a lot of reflective listening, and S for summarizing. And the other kind of motivational interviewing spirit of WINGS is really, as I mentioned before, is this spirit of collaboration, that we're working in partnership, letting the women as much as possible own and take charge of her situation and come up with the plans and goals that she wants to set, and draw out ideas and solutions from them, as well as with autonomy, really leaving the decision-making up to them. What type of services do they want? What do they want with in terms of pursuing relationship safety? So again, as I mentioned before, the focus is on incremental change with a continuum of risk reduction. We really want them, the end game is to increase their relationship safety, and that may mean for most women, that means who want to stay in their relationships, how can they stay safe in the relationship? And 80% of the women that we work with actually do want to continue in these relationships. And so the question is, how can they increase the safety? Identifying and prioritizing service needs with participants, making referrals to services based on their priorities, using social support to empower women to increase safety. So just to go through briefly the core components of WINGS, it's designed as a single 45-minute session that may be delivered, as I mentioned before, by a range of helping professionals and lay professionals, and focused on the following components. One is to provide a brief interactive psychoeducation piece on substance misuse and the experience of different types of IPV and GBV. We actually walk them through that power and control wheel for women who use drugs that I showed you earlier, and using ORS to really help engage in a conversation. And then we do a screening for IPV using a shortened version of the conflict tactics scales and psychological maltreatment inventory, and provide feedback on their risks, as if they're low, medium, or high risk. And then we use, there's a motivational interviewing piece of eliciting motivation to really address IPV, pointing out some of helping them identify some of the negative consequences of the relationship conflict or abuse on their own well-being, mental health, the well-being of their children, and their whole working situation as well. We then follow up with the classic IPV safety planning tool, which we've adapted for women who use drugs. And this is a tool that really helps women consider what they might do to increase their safety during an argument, or if they can feel that an abusive episode coming on, things like memorizing numbers they may need in an emergency, planning how they would escape if they need to, how they can talk about their children about safety, like using code language if they need to call 911, and then preparing like an emergency bag if they need to leave with house keys, car keys, all their documents, etc. And also how they can protect themselves if they're at work. So that's followed by thinking through different strategies that they can use to enhance their social support for if they need a place to stay, if their partner's coming home drunk, where they can immediately call someone to have a place to stay, or a friend that they can call to really turn to for emotional support and advice if you know, they're going through a hard time with their partner. And then it links through, you know, helps them identify and prioritize a wide range of service needs from, you know, emergency kind of housing or domestic violence services to things like employment services for themselves and their partners or housing needs, and then comes up with a referral plan to link them to IPV and other services. We have a whole referral list of resources that we had developed for this particular study that we felt were in good resources for women who use drugs in the criminal justice system, but it really is tailored towards a specific population. And then there's throughout we do goal setting that they can to improve relationship safety and reduce IPV, and we using this sort of SMART acronym of setting goals, which means setting specific goals that are measurable, attainable, relevant, and time-based. And we have them set goals in terms of how they can enact their safety plan, how they can follow up with referrals, how they can follow up with enhancing their social support. So that's what the model looks like in terms of, you know, if a case manager was going to develop. And now let me turn to what we were considering as we went through in terms of transforming this model into a computerized self-paced IPV SBIRT model and our rationale for doing that. So just to let you know, there's emerging research that shows that computerized self-paced IPV screening models have been found to increase the disclosure of IPV, and as you can imagine, they may provide a greater sense of privacy and confidentiality, particularly in settings where women are fearful of disclosure, and that includes criminal justice settings where they may not want to get their partners in trouble. It includes child welfare settings where they may get in trouble for having an abusive partner in the household, and also emergency department settings where they may not want to disclose to a stranger. So, and it also, computerized self-paced tools can extend the reach of IPV services into overburdened high caseload settings where service providers really don't have time to walk through this type of SBIRT session. The other advantage of computerized self-paced tools is they can be translated into different languages in settings where there are a lack of bilingual speaking staff. So in addition, the SBIRT models, computerized self-paced SBIRT models can be delivered with less staff training and expertise, and they can also enhance the fidelity of implementation and standardization of delivering a SBIRT model. You know, there is a wider range. An expert clinician can probably deliver this model in the best possible way, but the issue is with the level of staffing and training of staffing, what is the fidelity? With a computerized self-paced tool, it's standard. And the other advantage of a computerized tool is it incorporates narrative characters that can resonate with different populations of women who use drugs, and if found to be effective, they may be more cost efficient and scalable to implement. The other big advantage is that they can generate aggregate data that can be used to inform policies and programs to adjust IPV in different service settings, where to have a really good sense of where your participants or clients are at in terms of experiencing intimate partner violence and making cases for the need to integrate IPV services in different agencies. So some of the potential drawbacks that we thought about were, of course, you need basic computer equipment, technical assistance to deal with problems that can come up. Also, what happens if women become upset or distressed while they're going through the tool. And then we always think about a social workers, can a computerized tool really replace a clinical connection that a case manager or a peer advocate can provide in delivering this service? And can a computerized self-paced tool really effectively link women to IPV services? And then there is an issue also with computerized data, as there is with any data that we collect from participants or clients, is really how do we maintain the security of it? So that is actually, as you see on the front screen, that's what the opening screen to Wings looks like. That's the narrator that we chose with after having done a bunch of focus groups and in-depth interviews with our target population and other key stakeholders. So the Wings self-paced SBIRT tool is delivered with audio and was delivered on laptops in community correction settings. It covers the exact same core components that I went over before, using interactive exercises, videos with narrative characters, and computerized feedback. And the role of the case manager here was really which was one of our study staff who set up participants in the community correction sites on the computers in a room that had some privacy without a kiosk. They had headphones on. And the case manager just said, look, if you need any assistance during or after the intervention, please just raise your hand. And the case manager sat in the room a ways away to give the woman privacy, but was clearly there if she raised her hand. And there is a demonstration video that sort of walks you through it if you want. There's a link. So in that first brief psychoeducation piece, we actually incorporated 3 stories of women from a documentary who talked about their different experiences of sexual, psychological, and physical violence, and as well as their experiences of loving their partners and their partners becoming jealous and not recognizing these abuse symptoms. I want to also show you in the upper right-hand corner, we didn't collect any personal health identifiers or any personal information on the women. They had a computerized code that was randomly assigned to them. And there is also an audio clip that you can see on the left-hand counter that could read out the questions or any text to them, so it was appropriate for low literacy folks. And this is just one of the items in the screening tool that we used. This is one of the items that we used in the safety plan, just to give you a sense of what that looked like. Here's the social support map that we used, and it was interactive, where they would fill out different names and at the end get feedback on the different people who could provide different types of support for them. Here's goal setting exercises of things they could do to strengthen their support in the next week. And then the goal setting, we really ask them to choose what the best outcome would be for themselves and their partners, and with these options, and also the option to write in any other desired outcomes. And these are some of the resources and the referrals that we ask them to consider based on their goals. And if they pressed IPV services, these are the types of services that would come up with all the referral information. So just to go over the findings from the trial, the average age was 34 years, about 97, almost all of them were either Black or African American or Latina. 84% were unemployed. 71% were single, never married, but this is important to remember, 2/3 of them had children. And I also want to say that 88% reported having male intimate partners, and 18% had reported female intimate partners. About 12% reported having both male and female partners. So what we found is there, in terms of our first outcome, is what was more effective in identifying different types of IPV condition. If you look down to the third row, any physical or sexual IPV, almost identical in both conditions, 47% for both. And if you look at the second to last row, we found almost, if we looked at any physical, sexual, psychological, or severe verbal IPV, all types of IPV, it was 77% for both conditions. One of the things I want to mention here is the case manager, again, was our study staff. It was not someone from community corrections. I'm not sure we would have had the same rates of disclosure if the case manager was from community corrections, for fear that women would have in disclosing them, abuse to them. So in terms of the effects of the computerized versus the case manager versions of WINGS on our other outcomes, there was no difference between the two study conditions on any of the outcomes from baseline to the 3-month follow-up. Both were equally effective in increasing the number of women who were linked to IPV services, increasing IPV self-efficacy, increasing level of social support, and reducing the number of days not using drugs. There were some differences in the strength and in the significance, I mean, in the strength of the effect sizes with these, but they both were significantly improved on these outcomes. So in terms of our thinking through feasibility, safety, and acceptability issues, it was almost identical in terms of the length of time it took. The computerized WINGS was slightly shorter, 44 minutes compared to 46 minutes. No adverse events were detected by our study staff or by folks in the community correction settings. And in terms of acceptability, both WINGS participants from the computerized condition and the case manager condition reported that they were very satisfied with the intervention. So some of the limitations of this randomized control trial: we didn't have a control group. We did that for ethical reasons. We didn't have a longer-term follow-up of outcomes. We didn't address perpetration of intimate partner violence, which I think is important. And we didn't measure IPV as an outcome in order not to bias the screening of the IPV outcome. So in terms of the conclusions and implications, the outcomes suggest the feasibility, safety, acceptability, and effectiveness of both modalities. The extremely high rates of any physical or sexual IPV in the past year, almost half of the women reporting this, I think really underscores the serious public health threat of violence in this, among women who use drugs or alcohol in community corrections. And implementation research is really needed to, I think, further evaluate the cost effectiveness and optimal combination of both modalities of WINGS for different settings. So now I'd like to go back to polling and ask you, how comfortable would you be screening women who use drugs for intimate partner violence using the case manager modality of WINGS? So we'll present the results when it comes back. Takes a few minutes. Okay, we have a slight bump up from before. That's good to see. And how comfortable would you be screening women for intimate partner violence using the computerized self-paced modality of WINGS? Okay, we have an interesting, again, similar, a little bit higher in some categories.
All right, so talking. We want to be able to offer wings to other organizations that would like to deliver it. And the version that we had before was built in a custom environment, and the technology has eventually degraded. So Louisa and I worked together to figure out a solution for how we could offer wings. And so we have come up with a version that can be delivered if you have a QUALTRICS license. And it is exactly the same as the previous version of Wings. It has the same media and audio and QUALTRICS. And there's some benefits to that in that QUALTRICS makes it much easier for any given organization to adapt the safety planning and service referral sections to their own local information. If you do want to use Wings, what we would do is we would send you a QUALTRICS file. You would upload it and enter your local information into the areas that require it. We've also written a guide for how and where to do that. And then you would have clients visit the survey on a computer, a tablet, or they could visit it on their own phone if they have a smartphone. So if you are running a study about Wings, you could also do this using the QUALTRICS version, and QUALTRICS provides extensive data reporting, viewing options, and is, or at least can be made secure. So we anticipate having this version available very soon. I think it could be distributed in September, so just in a few months. So at the end of this session, I'm happy to answer questions about the logistics of this if people want to learn more.
Great, thank you, Jess. Okay. Okay, so in terms of our directions that we're going with Wings now, I think the promising outcomes from this trial may be relevant for emergency primary care settings, child welfare service, HIV/STI treatment settings, and you may, folks in the audience, have other ideas for it as well that I'm curious to hear. The lower cost of the computerized self-paced version of Wings and less staff burden may make it more scalable in community corrections and other settings. And Wings has been combined successfully with some HIV behavioral interventions and HIV testing and counseling interventions, which I'll talk about now a little bit. So we've recently finished completing a randomized controlled trial of WORTH, which is a group-based computerized HIV behavioral and IPV SBIRT intervention that's based on the Wings model with 306 women. And what we found was that computerized WORTH participants reported a significantly lower risk of physical IPV, severe injurious IPV, and severe sexual IPV at the 12-month follow-up compared to the wellness promotion intervention control group. And my colleague Nabila El-Basso, also who was a PI in the study, found that both traditional WORTH and computerized WORTH participants were significantly more likely to decrease unprotected sex at 12-month follow-up compared to the wellness promotion. However, we didn't find any significant difference between traditional WORTH and wellness promotion on any of the IPV outcomes. So this provides additional evidence of the possibility, the strength of the computerized self-paced version of the SBIRT model for reducing different types of violence. We also took Wings to Kyrgyzstan in Central Asia and combined it with HIV counseling and testing. And I mention this only because it can be done in very low resource harm reduction settings. And we evaluated Wings with 72 women with a simple pre-post design, and we also adapted wings to address the wider range of gender-based violence that the women were experiencing, and expanded it to a 2-session intervention with HIV counseling testing. And the study found very high rates of both intimate partner violence and gender-based violence. The police were one of the biggest perpetrators. And it was great for our collaborators and in Kyrgyzstan to have this data with the police abuse. And at the 3-month follow-up, participants experienced 59% fewer incidents of physical IPV in the prior 90 days than at baseline, and 27% fewer physical gender-based violence incidents. Participants were also 65% less likely to report using drugs and were more likely to receive gender-based violence services. And almost 90% successfully completed HIV counseling testing, which was much higher than what they were achieving before. So in terms of the future directions for us also, we're continuing to build a network of stakeholders with our partners in community corrections. They've been fabulous, and we're still exploring ways that we can scale up and implement wings in community correction settings. I was so happy that Jess has finished this QUALTRICS version of wings that can be delivered on phones and tablets. We're going to do some additional beta testing and schedule it for release in September. And we're also adapting wings for use in other settings that serve women who use drugs and alcohol at risk of intimate partner violence, and continuing to integrate wings into HIV and substance abuse treatment interventions. So just a few things to consider if you're thinking about implementing wings in your organization or another IPV SBIRT model. You know, things like staff training available. Do staff have available time to do it? Is there a leadership commitment, and is it consistent with the values of the organization? Is there funding to do it? And the need to build a network of services to refer women to. This is very important, and believe me, I know it's challenging to find domestic violence, particularly residential programs that will accept women who are actively using drugs. That continues to be a huge challenge, and one of the things I hope with this WINGS SBIRT model is to continue documenting that need. Does your setting have the tools to kind of the intervention manuals, all that place, which we'll have more in place in September to implement WINGS, and is there confidential space, which is more important for the case manager version of WINGS, but it's still important to have some sort of kiosk type of setting for the computerized self-paced version, unless women do it on their mobile phones and completely on their own, which is also a real possibility. Some of the other considerations before implementing WINGS is an approach. Do you want to do a universal type of screening versus a selected screening approach? It's very important to know the reporting requirements for IPV in your state and inform the participants and clients there to do that. Using informed consent, I think, is always sort of the best practice. Strategize how best to reach the women who use drugs, experience IPV, and who are not linked to services in your community. Really think about how you're going to get to that 9 in 10 women. Also, trying to think through whether addressing IPV or substance misuse first, I would, again, start where the woman is at. That's sort of the old maxim of social work. Ensure whatever screening tool that you use is tailored to the age, race, ethnicity, gender, and sexual identities of your target population. And again, as I mentioned, is really to build that network of IPV-related service referrals and partners, thinking through a service integration sort of program collaboration type of model. So these are just some of the range of services that I think you need to consider. Let me just go back here. As you build those services, think again about what services are geared towards the age, race, ethnicity, sexual orientation, and wide range of partnerships that your participants or clients may have. Women-only centers or women-only hours, thinking about hours for women who may be working or responsible for childcare, thinking about services located in areas and neighborhoods that are convenient to women, and services with peer advocates that can support other needs of your women. So let me just do another quick poll here of, for those of you who are working in organizations, how big of a barrier is lack of staff time to conduct a case manager delivered IPV SBIRT like Wings with Women? Very big, big, little, not a barrier, not applicable if you don't work in this setting. Okay, so there seems to be a range of how big of a barrier it is. You guys can take a look at the results there. 15% say not a barrier, 10% say very big, and 22% say big. Okay, how big of a barrier is lack of staff time for your organization to conduct a case manager delivered by, should be lack of staff training, it looks like, to conduct a case manager delivered IPV SBIRT like Wings with Women. Staff training, I'm sorry, everyone. And again, there's a range here. 11% saying very big to 15% saying not a barrier. Most were in between for the lack of staff training. Okay. And how big of a barrier is lack of, wait, we did that one before. Let me just get this one. Okay. Trying to, let me jump to the next one there. Oh, how big of a barrier is lack of support from leadership to conduct a case manager delivered IPV SBIRT like Wings with Women in your organization? Lack of organizational commitment to the issue. So about a quarter said big or very big, and 20%, almost half said a little or not a barrier. So that's good. That's good to see there is overall a commitment. And then in terms of service referrals, how big of a barrier is lack of IPV services in your community to conduct a case manager IPV SBIRT with Wings with women who use drugs? Or so we have about 30% saying very big or big, and about 45% saying a little or not a barrier. Interesting. Okay, this is helpful for us. And in terms of how interested are you in additional training on Wings implementation? We're trying to plan for what trainings we may need in the future, and how interested would you be in an in-class training? Very interested to, not sure. Okay, so we have a good number who would be interested in in-class training. Thank you. And I'm just going to ask you one more question here. How interested would you be in doing an additional training on Wings using an online training? We're just trying to think about what formats would be most helpful. Okay, so it seems like more of you are interested in the online training. This is helpful. Again, thank you. Just trying to get to the last slide here. We're almost done. This is our last slide. So I just want to sort of, again, communicate our vision of WINGS and with you all. And it really is to help find those 9 in 10 women who use drugs, who are experiencing IPV, who are not receiving services, and enable them to develop strategies to increase relationship safety. We're also very concerned about you know, the ongoing need to collect data on different types of intimate partner violence to document the scope and severity of this severe public health threat of IPV among women who use drugs, and data that can hopefully guide policy and program efforts to redress intimate partner violence among different populations of women who use drugs. And I just want to thank you all for continuing throughout this webinar with me, and thank you to Tracy and Misty for hosting me.
Well, thank you. No, thank you. I really appreciate the two of you sharing your expertise in this area, and in this context, the link between what many of us are familiar with SBIRT or SBIRT in addressing other substance use issues. I don't think as many of us are familiar with how SBIRT and IPV identification and intervention sort of come together, and I think so this is new for many people who aren't familiar with the application of the model or the WINGS program, and so I think this is enlightening for many of us. So thank you for sharing your expertise. I do hope that we can continue to work with you and your colleagues in our 2017 series to offer more on this topic and working with this particular population. So I hope there's more to come out of your work. We're going to open it up to questions, so I'm going to pause for a second and pull up the questions we have so far, and also remind folks that you can ask a question if you're not familiar with the GoToWebinar panel. You can see typically in your upper right-hand corner there is a panel, and there's one little area that says questions. If you click on that, it'll pop up and show an area where you can type in your questions. Feel free to do that now. We've already had some come in, so I'm gonna go ahead and field some questions to you. And Dr. Gilbert, I'll just field them to you, and then if you think it's really more appropriate for Jessica to answer, perhaps you can throw that one over to her. How's that sound?
Will do. Thanks. We're ready. Thanks so much.
Okay, terrific. This is a really great question. Have you applied this program or used this model or the WINGS intervention with men? And if you haven't, any thoughts about it?
That is indeed a great question. Yes, we have really thought about adapting it for men and making it completely gender neutral, and just have not had the resources to kind of move forward on that angle, but would love to see this adapted for men. It is really needed, and I do think a gender neutral approach is the way to go with it and adapt it for men. I would love to see that happen. We just have not managed to make it in that direction yet. But would love to see other people do it too. So.
Well, that's helpful. That's helpful. I think there are several questions. Could it be, hypothetically, could it be applied, or is it really exclusively for women. It does sound like there's an opportunity, maybe not a lot of research there.
Absolutely, that can be adopted for men. Men experience, you know, same types of psychological, physical, and even sexual abuse, and in same-sex and in heterosexual relationships. It's, I think, much needed, and I think sort of the idea of asking both as, you know, their experience of it as a survivor of IPV as well as a perpetrator of IPV is really important, to really take a stance that this is about relationship conflict and what experiences do you have, and really getting, and that will help in terms of really making the assessment of what types of interventions they may benefit most from. It could be that, you know, they also need domestic violence services, or they may need anger management services, or they may need, you know, couples treatment, depending on the type of violence and the mutuality of it.
Thank you. That's encouraging, and I think folks want to hear that and are interested about the application. So thank you. I have another question. So you mentioned earlier that women who talk to a healthcare or social service provider, professional, may be more likely to leave an abusive relationship. Can you talk a little bit more about that? Is that a one-time conversation? Is it multiple conversations over time, or is it multiple intervention-like conversations? Can you talk more about that?
Sure. I mean, that was a study that was done in 2006 by McCloskey that sort of talked about that as a they found that outcome, that women were more likely to leave an abusive relationship after they talked to a healthcare provider about IPV. So we didn't actually find that in our work, so I want to make that clear that I was citing other research on that issue. I would say with the women that we go through, most want to stay with their partners, but there are a few that we really did help to leave, and the idea is to really let them drive that change.
Okay, thank you. Now this may also be related to another study that you either presented, or maybe this is your study that you presented. I can't tell from the question. But did you look at the correlation between IPV and sex work?
That's a great question. We are actually looking at that in our current study of women who use drugs in Kyrgyzstan, and we've developed the wings. We just are in the process of adapting wings for sex workers. So, and looking at all the different types of violence that they experience, not only from their intimate partner violence, but from clients and also from police, and addressing safety planning on, you know, that would address all those different types of relationships and potential violence that they may experience. So we are currently doing that, yes, in our Wings project in Kyrgyzstan.
Thank you. With the self-paced tool that you were talking about, have there been any difficulties with, let me make sure I'm interpreting this question correctly. With a self-paced tool, has there been any difficulty with women who use drugs or alcohol identifying emotional or verbal abuse as an aspect of IPV? Is it made clear through the questioning process? There were similar rates of psychological and verbal IPV that were disclosed in the case manager and the computerized self-paced version. So I would say that the tool was equally effective. I don't actually have the rates. I can go back and take a look at that slide, but we did present on psychological and verbal abuse, and the rates were very similar. Yeah, the case manager, the average score for the psychological scale was 7.3, and on the computer, the average scale was 7.0, so very similar rates. Okay. All right, let's see. Another question for you. Well, this is more of a comment. More than a comment than a question.
Good, I like comments too.
This person says, well, I think it would be better to have a discussion with the patient rather than an automated computer questionnaire.
I get it. I get it. You know, and I want to go back to say it all depends on your setting. If you are working in a substance abuse treatment setting and you want to incorporate that as part of your clinical practice and really understand how the relationships are working, I think it makes sense to do it in the case manager version of it. Similarly, if you're in an IPV setting, if you're going to continue working with them on an ongoing basis and you can address this issue in whatever practice or setting that you're in, I think it makes sense to do the in-person version of it because it allows you to really assess that aspect, that domain of their life, of their relationships and potential for relationship conflict and how it's triggering substance abuse and strategies for addressing that. So I think it all depends on the comfort level of the provider, their expertise in addressing intimate partner violence, and the setting. So in deciding through what modality may work best for you and your setting, those are important questions to ask. So I'm glad you for that comment. Thank you.
All right, let's see. Is the computerized tool available in Spanish or other languages, or are there currently any efforts to adapt them?
Right now, we haven't gotten the funding to translate it and make it available in Spanish in the computerized tool. It's something that we would love to see happen. It's really a question of funding and resources that we haven't been able to do that yet. But I think it makes a lot of sense in terms of reaching a much wider range of women who are at risk of intimate partner violence or using drugs, and there is often a lack of bilingual Spanish-speaking staff who can work with them.
That's great. Well, that sounds like some future work ahead.
Mm-hmm.
Let's see. We have another question for you. And this may make a little bit be more clear to you than me. But the question is, did you, and I don't know if this was you, Dr. Gilbert, if this was Jessica, but did she say you have to have a corporation number? Does that mean something to you? Is that about
a what? What number? Is it?
A corporation number? Was that about the technology or something about being able to get access to the technology? Perhaps if the person wants to clarify their question a little bit more, I might be able to direct it, but a corporation number.
I think perhaps the person heard me say that you need a QUALTRICS license. QUALTRICS is a survey software, and it isn't free if you want to have a infinite number of people go through whatever survey you're offering. There is a free level of service, but I think it has a cap of 100 people. So after that, if you wanted to continue delivering wings with the QUALTRICS version, your company would have to pay for a QUALTRICS license. But that's the only thing I can think of that might have referred to.
Okay. So maybe a license for the software. All right. Let's see. Okay, here's a question for you. As a social worker, I think wings would be very beneficial to use with clients. Have you ever thought about bringing this tool to different universities that have social work programs?
You know, that's a really interesting question and thought in terms of training social workers to use IPV SBIRT models in a systematic way, because I think folks in a variety of settings who are not IPV specialists encounter the problem of IPV social workers do, and sort of panic in knowing how to address it. And this is a simple, brief intervention that sort of goes step by step on how you would, screen and refer women to services. So that's a great suggestion, and it is something that would, I think, again, a question of funding and resources to bring it into a social work training, curriculum. But it's a great idea.
I agree. I think it's a terrific idea, and as someone who's been working a lot to integrate SBIRT-related education to train our future social workers as well as the current faculty and instructors, I'd be very excited to look into this with you to see whether there might be opportunities. It does seem like a natural fit for sure. So maybe there's an opportunity there we can explore.
That would be great, Tracy. I would love that. It is great. It's a great idea.
This next question is about disclosure of substance use. So can this model be applied without disclosure of substance use? And how about with men? And maybe this is in particular in the context of which you're working that setting.
Yes, that's a great question. I think going back to one of the first slides I showed, I think it should be used if you're working in a setting where you're not sure if someone's using drugs or alcohol or not. I think it might make sense first to use a substance use SBIRT model and get a sense of whether they're using drugs or alcohol, and then do this IPV SBIRT model for women who identify as using drugs or alcohol.
Okay, thank you. Thank you. I think we have time for maybe one or two more questions probably. And let's see. Have you utilized or applied this model in, let's say, a workplace behavioral health setting like an employee assistance program?
See, this is why I wanted to do this webinar, to get other ideas of where it could go. No, and I think that's a great idea. I mean, it's something that could be, I think, adapted to an employee workforce setting, and one where it would be particularly helpful if again, women don't want to disclose experiencing intimate partner violence in a work setting where it might, a lot of women don't want to disclose it for personal reasons, and also don't want to, put their partners at risk if they're known to that work setting in particular.
Well, as someone who has spent a lot of time doing EAP and workplace work, I can definitely see the fit as well. Lots of opportunity, I think, here. I think there are several questions I could probably bundle in one. So if someone is interested in the computerized program, wants to know about the technology specs of what does it run on, how much does it cost, do you offer training, can anybody use it, who would you suggest that they reach out to for those kinds of questions?
Dr. Gilbert, you're on mute.
Oh, thank you. They can email me. I have put my email address on this presentation, and I want to let you all know that we are planning to launch the computerized self-paced version in September, and we're also updating the manual for dissemination in September, and plan to do a training on September 23rd here at Columbia on the model. So if you're interested, please do email me, and I will get back to you and put you on our list for these trainings and dissemination when the intervention guide is ready for dissemination, as well as the computerized self-paced version in September.
Terrific. Well, we tried to get to most of the questions, as many as we can. There are a few that remain, so I apologize for not being able to get to all of them. But I imagine if you have a burning question, you can certainly let us know, and we could potentially field that for you. Or Dr. Gilbert, if you feel comfortable people emailing some of their follow-up questions,
Sure.
they have your email address.
Sure. I'd love to hear from you. And
Terrific, terrific. Well, in our last few minutes, I want to thank Dr. Gilbert and Jessica Rowe very much for the education they provided us today and really talking about the work they're doing. And I want to let all of the attendees know that there are PowerPoint slides available to you already posted up on the web in PDF format. And we have the certificate of completion that you will be able to request and get a copy of. We would like to make sure that you complete the evaluation survey first before requesting your certificate of completion, if at all possible. The evaluation survey is really critical to the success of our project and maintaining our funding and ensuring that we're able to bring in really valuable education and presenters like our wonderful presenters today to offer you their expertise. So please complete that evaluation. It takes just a moment to do. For those of you who may be sharing this to your colleagues or accessing it in the future as an on-demand recording, that will also be posted here to the website. After you have viewed the on-demand recording, you can complete the on-demand evaluation survey, and you can then complete a certificate of completion. All of that information is also available on the webpage dedicated to this webinar. You will also receive a follow-up email with additional information and reminders, but if you can take a few minutes to do the survey now, we would be grateful. And I want to close by saying thank you to everyone for joining us today. I hope you'll take advantage of all of the on-demand webinars that we have available to you. And we want to thank our partners, the Brief Intervention Group, NORC at the University of Chicago, and the National SBIRT ATTC for bringing this together. And if you have any questions about SBIRT implementation, evaluation, training, you're looking for technical assistance by telephone or email, you're welcome to contact me and follow up as needed. So thank you everyone for joining today, and I appreciate Dr. Gilbert and Jessica, your expertise. Thank you, and I hope to have you all on a future webinar. Have a good day.